Okay, I think we'll go ahead and get started. I wanted to thank everyone for coming to the 24th Annual Garbose Lecture. This lectureship is supported by the Garbose family in honor of their daughter, Emily Cara Garbose, who was born with pathology of Cantrell. This is a rare defect that includes ectopia cordis, where the heart is located outside of the chest wall, and is often associated with congenital heart disease, and in her case, she had a diagnosis of Tetralogy of Fallot. Sadly, Emily at that time did not live long after birth, but her family remains quite committed to supporting education and research in congenital heart disease here at Children's National. So this morning, along with Dr. Barul and the Division of Cardiology, it's my pleasure to introduce Dr. William Hellenbrand. He is a professor of pediatrics at Yale University School of Medicine and the previous director of pediatric cardiology at Yale. He completed his pediatric residency and pediatric cardiology fellowship at Yale New Haven Hospital and remained there as faculty, and soon became the director of their pediatric cardiac catheterization lab, and he held that position for about 20 years. In 1999, he then moved to New York City, the Children's Hospital of New York Presbyterian Hospital, became the director of invasive cardiology there, and then also finally became the director of pediatric cardiology there in 2007. In 2011, he returned to his alma mater, in a sense, Yale New Haven Hospital, as the director of pediatric cardiology. Dr. Hellenbrand is a pediatric cardiac intensivist, or sorry, interventionalist, and is one of the leading interventionalists in our field. He has participated in the design, development, testing of various transcatheter therapies for the closure of septal defects, stent implantations, and multiple studies leading to the clinical use of two innovative valves that involve tissue engineering that he'll speak about today that are often used in the repairs or further repair of Tetralogy of Fallot. So he has over 100 publications in our field. He has been and remains a mentor to many of our faculty here at Children's. So please join me in welcoming Dr. Hellenbrand for his lectureship entitled Pathophysiologic-Based Transcatheter Management of the Postoperative Patient with Tetralogy of Fallot.
Thanks very much. Thank you all very, very much. It's a pleasure to be here, renew acquaintances with some old friends here, former residents, former fellows. And this morning I was greeted by a former classmate of mine in medical school showing me my picture when I graduated medical school along with his. So I get to see a long-term spectrum of acquaintances here. What I'm going to do today is try and talk to you about one of the most common forms of congenital heart disease. It's a little bit about a story of how we figured out early on how to correct Tetralogy of Fallot in the operating room, and it still remains the procedure of choice. The only way to correct Tetralogy of Fallot is in the operating room. But where we felt we really had done a really good job, and if you go look at the data, which I will show you a little bit of in the 80s, we've now come across the fact that this is really a long-term medical problem that is lifelong, and a lot of the things that we did to correct them has led to just further troubles down the line, and we have to rethink how we manage these patients. I'm going to show you some of the new treatments that we have offered now in the cath lab instead of going back to the operating room, but we need to apply the same principles to that procedure, and that we have to really look at it critically, seeing if it's the right thing to do. We made the mistake once, thinking we really had the answer lifelong for patients with Tetralogy of Fallot. We really now have to go on to a different approach and new innovations as adults. So you're going to see a lot of information here as adults as well as pediatrics, but I think it's important to recognize what we take care of is going to be future problems for other physicians and other caregivers. So if I can get the thing to move forward. Since they put me on WebEx here, I can't get it to go forward, guys. We'll go back and forth now?
Yeah.
Okay. So these are my disclosures. These two companies make the valves that I work with, and we are going to talk about off-label use of medical devices. So I also think it's important to understand what I'm trying to get out of this lecture, and I did supply these learning objectives previously. I would hope that everyone here can understand and categorize the pathophysiologic states after this repair, summarize some of the newer transcatheter therapies available to these patients, and also appraise some novel therapies that are on the horizon coming forward. So if one looks at the data across the country, across the world, the ratio of pediatric adult patients with congenital heart disease is kind of fascinating. It just tells how successful we've been in survival. And then we're going to talk more about quality of survival and morbidity. But if you go back to the 60s, many more pediatric patients than adult patients. It's got to do with mortality, and I will show you that slide in just a minute. Somewhere in the 80s and 90s, early 90s, it became equal. And somewhere in early 2000, we have many more adult patients than pediatric patients with congenital heart disease. That's going to continue to grow because the number under 18 is pretty fixed, while the number of adults keeps growing. So this is becoming a real long-term problem, and what we do in pediatrics really affects how they're managed and what the outcome is and the problems they see in adulthood. This is a slide from Canada, which talks about the age of death in patients with congenital heart disease in two different time frames. The first one is the year 87 to 88, and the second one is in the mid-2000s. The black line represents the average age of death in the normal population. If you look down here on the left at 87, 88, the mortality among patients with congenital heart disease, over 25% mortality occurred in the neonatal age group or under a year of age, the infant age group. And then a lot of our patients didn't survive or died younger than the normal age of death. If you look at the year 2000, except for some still increased mortality in the neonatal period compared to the normal population, you can see that we've done a really good job of survival. Patients are living longer, and they can pretty much die at their expected age, not all the time, but on average is where they are. And this is all kind of complex and simple. And becomes a real important part when you also recognize the fact that congenital heart disease is the most common congenital defect in the world. More so than any other disease that you guys take care of, but it is the most common congenital defect. So we can get them to survive, but we have to talk a little bit about the quality of survival. So let me briefly review the anatomy of Tetralogy of Fallot and a little bit of how they're managed in the operating room, and then we'll go into some of the longer-term issues. The picture on the left is pretty much what everyone can see. It's a sort of a normal status where desaturated blood starts from the right atrium, goes to the right ventricle out to the pulmonary artery, and saturated blood comes back from the lungs, left atrium, left ventricle, out to the aorta. Two pumps in series. That's the way the heart works. And this is a patient with what looks like when a patient with standard Tetralogy of Fallot. Now, you read a lot about the blue baby showing up with quite cyanotic and having PET spells with hyperpnea, cyanosis, and loss of murmur. We don't see that anymore. Oh, rarely see it anymore. If we see it once. Because once it happens once, they go right to the operating room to take care of it. We try to get them in the operating room 3 to 6 months on average to take care of it. We don't see that in this country. We do see it in other countries. Tetralogy of Fallot, which means it's called 4 defects, but there are really only 2 defects anatomically that are important. That wall that separates the right ventricle and left ventricle has a large ventricular septal defect present, and the connection from the right ventricle to the pulmonary artery has obstruction. So there are 2 problems here. There's a large VSD and there's pulmonary stenosis. In effect, what happens is that blood ejecting from the right ventricle can't all go to the pulmonary artery like it's supposed to. Some of it goes right across the VSD out into the body, giving you desaturated blood in the body, causing the cyanosis. And this is variable. And the TET spell is when it gets really severe and there's very little pulmonary blood flow going forward, most of it going to the body. And what's done then is if you look at just the picture right here on this top right panel, As part of surgery, and I'm going to say this very simply, it's not terribly difficult surgeons. The surgeons do it all the time, but it's involved. The VSD patch has to be closed, and this area of narrowing has to be relieved, so there's no stenosis in that area. And the most common way of doing that is what you see here. The opening is sort of opened up on the outside surface, and then a patch is laid on top of that area to eliminate all obstruction in that area. It's commonly performed between 3 and 6 months of age. The mortality is less than 1% at the time of surgery. But understand what you've done. You've cut across the pulmonary valve area. You've removed the pulmonary valve in many patients, not all patients, but sometimes, and you're left with free pulmonary insufficiency. So there's no functioning valve in that area in many of those patients. And this is sort of what it looks like, just to show you. This is an angiographic picture from a cath lab. This is the pulmonary artery. This is the region of the pulmonary valve. This is the region of where a patch was placed. You can see this area is widely open, and there's no near narrowing, but this valve does not function very well, as I'll show you in a minute in this patient. And as I said, it's the most common form of repair of tetralogy of Fallot. And if you look at this MRI on that patient you just saw there, you can watch the right ventricle squeeze, and then you can see blood going forward and backwards. This is basically a free pulmonary insufficiency. And many times when you measure this by MRI, the regurgitant fraction, that is how much comes back that has gone forward, is over 50%. 50, 60% of the blood going forward comes back. It's not really good for you long term, as we'll show you that in a minute. Now, there's one other type of severe form of tetralogy of Fallot, the tetralogy of Fallot with pulmonary treatment. When that connection, the VSD is there, sorry, I didn't mean to do that. The VSD is there, but you can see that the connection from the right ventricle to the pulmonary is gone, or is very, very tight and very, very small. And surgery, without getting too complicated, involves closure of the VSD by putting a graft, a conduit, from the right ventricle to the pulmonary artery, usually with a valve inside of it. That's the least common form. That is the form that with the original valves I'm going to show you, transcatheter valves, were designed to treat, but now we've begun to expand the use of those valves to treat both types of problems, the ones with free pulmonary insufficiency and the ones with conduits that are present. These are the various conduits that the surgeons use. There are homographs. Sorry, guys. It's very sensitive here. There are homographs. There are xenografts. There are bioprosthetic valves, and there are various types of valves that the surgeons can use. All these grafts will not survive long term. Almost all these patients will undergo degeneration. So the smaller percentage of patients with tetralogy of Fallot have these grafts. And you can see in the picture on the right quite a severe narrowing right here, which you can see is one of the consequences. So a lot of problems with the conduits, they get stenotic. So we end up with two different groups of patients, patients with stenosis after surgery, and then the majority of patients with free pulmonary insufficiency after surgery. And that's how it works. Just in summary, just to go again, as I was just explaining to the patient, the majority of the patients on the left are the patients with a patch with free PI, and the patients on the right with conduits, they become obstruction, which we'll talk about the two different physiologic states after repair of tetralogy of Fallot. So you go to the literature, and you read about tetralogy of Fallot repair. You go to literature from the 60s, 70s, mostly 70s and 80s, even early 90s, that repair of tetralogy of Fallot was curative. They use the word curative in the literature in the textbooks. And the consequences of a wide open outflow patch with free pulmonary insufficiency was minimal. Now, we didn't have a lot of follow-up yet, but that's what they thought that was the case. But it's become clear over the years that this repair is very good palliation in most patients. The near certain death in a neonate with tetralogy of Fallot or an infant from profound cyanosis has been traded now, as I'll show you, for a definable incidence of right heart failure, arrhythmias, and sudden death in these patients. So, and this has clearly been related to the fact that we've left them with physiologic states that are not conducive to normal activity and normal growth and normal activity and normal longevity. Pulmonary incompetence was regarded as inevitable but unimportant sequelae of repair. Emphasis was placed on complete relief of obstruction at the expense of a regurgitant valve and ever-dilating outflow tract. Just think about that blood washing back and forth continuously, 50% of it coming back, and they kept on dilating that right heart. Now, the misguided assertion of early investigators that free PI was unimportant can be really understood when one considers the time course of the presentation of symptoms. You don't see symptoms in these patients until decades later. So there's a lot of consequence to what we do to our patients by how we operate on them early on, but it really wasn't decades to 2, 3, 4 months after repair. So let's talk about the two different physiologic states that we do see after repair of tetralogy of Fallot. The first one is severe residual stenosis. That's pretty easy to identify. Patient has a prominent murmur. They're followed by cardiologists to get routine echocardiography. They find evidence that because you have residual stenosis, the right ventricle gets thick, gets hypertensive. It has to push blood through there. These patients can develop severe symptoms of easy fatigability, chest pain, and they usually symptoms present pretty early after repair or pretty early after they develop stenosis. And their intervention is associated with relief of symptoms and improved exercise performance and some remodeling of the right ventricle. But I'm going to show you that the way we treated these patients with significant stenosis was that either went to the operating room to get relief of the stenosis and we created PI, wide open PI in these patients, or we took them to the cath lab. We put a stent in that narrowed area, made it wide open, and what we traded is to the other physiologic state, free PI. So the second physiologic state is severe pulmonary insufficiency with now a volume overloaded right ventricle because there's so much blood coming back and forth and washing in and out. Over the decades, this patient developed decreased exercise tolerance, cardiomegaly, arrhythmias, sudden death, and chronic congestive heart failure from these patients. Now, sometimes you didn't see this for 3 or 4 decades. Sometimes you saw it 20 years later. But this was a late onset phenomenon. And if you go look, if you operated on them back then, when they presented with symptoms, and this could be 30 or 40 years later, you get improvement in symptoms in every one of these patients. They feel better. We can't objectively measure a lot of improvement by exercise testing, but they do feel better. But as opposed to a heart muscle that goes into dysfunction because of obstruction, you relieve that obstruction, then the heart muscle gets better. If you have a chronically overloaded heart with the heart muscle not contracting very well, and you relieve that regurgitation, frequently the function does not improve significantly. So the question comes up is that if we did this sooner or changed the way we did surgery earlier on, would this be better for the patients? Now, the surgeons have changed their technique of doing this repair, and maybe Richard can speak to this later, and that we've really changed the way we do this, try to prevent these long-term issues. But the premise we all do as cardiologists now, but maybe we need to intervene early on these patients with severe PI to try to reduce or eliminate some of the long-term consequences. And why is PI bad for you? I'm not going to spend a lot of time in this particular slide. This is an animal model testing of inducing PI by taking out a valve in an animal model and looking at what we call pressure volume loops. Pressure volume loops is a way of us evaluating cardiac function and how in its response to stress, either pharmacologic stress or exercise stress. And we look at both the right side and the left side of the heart. We think it's just affecting the right side. So free pulmonary insufficiency creates, as you can see up here, the right ventricular end diastolic volume, or the volume of the right ventricle goes up, and their RV function goes down in these animals. If you look at on the left side, it's interesting. The left side volume goes down because not enough blood is going forward to the left side, so therefore your heart function, it can't put out more blood in response to increased demands. Some studies show normal LV function, some studies show reduced LV function, but if you then test them to a pharmacological stress like dobutamine, the controls, the stroke volume increases by 25% in both chambers. If you look at the patients with the PI model, stroke volume on the right side only increases by 3% and on the left side only by 9%. So therefore, we've reduced the ability to augment our cardiac output in the face of stress. And this is one of the problems of pulmonary insufficiency. So what is the breakdown of the patients who have residual obstruction or residual pulmonary insufficiency? This is a slide depicting all the anomalies of the right ventricular outflow tract which require surgery. About 20% of all our patients have anomalies of the outflow tract, the vast majority of tetralogy of Fallot. So about 20% of all the patients, and probably only about 10% of tetralogies, require that conduit. The rest of them all have that free pulmonary insufficiency. And that's the big group. The initial work that we did was to treat these patients with the conduits, but now we're trying to extend it to all patients now because this is the patients with the biggest set of problems. And also, when we try to treat the conduits just by getting rid of the stenosis, we just move these patients over to the other group. Now, this is a paper out of the Dutch and the Netherlands looking at long-term sequelae of patients who were operated up to 40 years ago. I'm sorry it came out a little bit small, but on the left side, you can see survival of tetralogy of patients up to 40 years out in a group of patients operated on standard manner Tetralogy of Fallot. So you look at survival, the black line on top is the normal Dutch population, and this is survival of tetralogy. So there's not an insignificant mortality in these patients going along. They don't have normal lifespan in this particular presentation. Of interest is the patients on the right. This is the incidence of interventions, all interventions, and then pulmonary valve interventions in the red line. Most of the interventions are the need for pulmonary valve replacement. So most of these patients end up with a pulmonary valve replacement, and a lot of them being done at 20 to 40 years out of the line. So these patients get very sick and very symptomatic. The question comes up, if you did it much earlier, would they have a better outcome? And what techniques are you going to use? Because in order to give them a competent valve, one has to put a bioprosthetic valve or a conduit in there. These conduits continue to fail. These bioprosthetic valves continue to fail. So if you want to keep them competent, you got to keep operating on them over, again, some of these patients have come into our study, which I'm going to show you about, have had 3, 4, 5 open heart surgeries in the past. And that makes these patients want to find an alternative, and we'd like to find an alternative, at least to decrease the frequency of the number of operations so we can just treat them better and keep them out of the operating room as frequently as they tend to go. So these two slides would indicate to me there's still a lot of work to be done for that. So let's tell you about how we treat this in the cath lab right now. This is what we did for pulmonary stenosis. This is a patient who has a repair of Tetralogy of Fallot. You see the picture on the left. This is the right ventricle. This is the pulmonary artery up here. This area connecting the two is quite narrowed. And you can see this is a patient whose most of the problem was pulmonary stenosis, but had some pulmonary insufficiency. We went ahead and put a stent in that outflow tract. Not difficult to do. We were doing it for a long time, and we got rid of the obstruction. His symptoms went away, by the way. This guy had exertional symptoms. He was symptomatic with any kind of significant exertion. But what have I done here? I've created a model of pure pulmonary insufficiency here. So this is not in this patient's best long-term interest. And we know we can do this well. These are just to show you we have a lot of different stents that Josh uses frequently in the cath lab to relieve various obstructions. So we have a lot of toys we can use to work with this. But right now, these stents, the way they're set, as you see here, only does switch our physiologic state from obstruction to regurgitation. And neither one of them is good for you. And this is just an article that came out of Boston Children's a number of years ago looking at stents in the RV outflow tract. You can see here a picture of a really tight area treated with a stent and relieve the obstruction. These are just graphs to show you we're really good at relieving obstruction. And this is before we had the concept of using valves. But this is now something we don't do anymore unless there's no other option to do this. So what's the goal of the therapy should be going forward? The goal of the therapy needs to be restore and maintain pulmonary valve competence. But we have to provide relief from stenosis without the risk of regurgitation. This is hard to do because without going in there and putting a functioning pulmonary valve in there, surgically or in the cath lab. The problem with surgical valves in the right side, most of them are bioprosthetic valves, is they have a finite lifespan and some of them will fail, especially in the younger children. The younger you are, the least longevity of those surgical valves. So if there's a way we can put in valves, short of repetitive open heart surgery, prolong the life of existing valves, and take the patient into the number of times they go to the operating room less frequently, I think that's a good thing for the patient, and the patients certainly agree with me. So there are 2 valves that are out there now. I've worked with both of these valves investigationally, but most of my work was with the Melody valve. They are transcatheter valves that are delivered. The valve on the left is the Melody. It's a bovine jugular venous valve. It's a platinum stent. This was designed for the pulmonary valve position. It has no other use. It's been used in other valves, but it wasn't designed for that. It was designed to be delivered, to put in the pulmonary valve, and over 10,000 of these have been implanted around the world already for the pulmonary position. The valve on the left, you may have heard, the valve on the right is an Edwards sapien valve. This is a transcatheter aortic valve. It's been designed for use in now hundreds of thousands of patients percutaneously in adults with aortic stenosis. Now, there was a trial of using that valve in a technically challenging way to put it in the pulmonary position to see if it worked. and now about 1,000 of these have been implanted. The one on the left comes from the jugular vein of a cow. The one on the right is pericardial leaflets from a cow and a cobalt chromium stent. So the MELODY trial was designed, this is what it states in the trial, to prolong functional conduit life, because the MELODY valve was designed to go inside a conduit when there was stenosis or insufficiency and return confidence without stenosis. So the design was to restore and maintain pulmonary valve confidence and provide relief from stenosis without the risk of regurgitation. Thereby, you don't want a stent. You want a stent with a valve inside of it. So I'm going to go back to this picture one more time and look at all these pictures, guys. Those are valves sewn inside a stent. So this is a stent to get rid of stenosis or find a way to hold on to the area where you want to put it, and there's a functioning valve inside there which begins functioning as soon as you open that stent when you deliver it. So just to show you what it looks like, this picture on the top left, it's a human pulmonary valve in a hanging preparation. The picture on the right, that's a MELODY valve in a hanging preparation. I think the human valve is a lot more elegant than the MELODY valve, there's no doubt in my mind, but it's a very, it functions pretty well. It's a trileaflet valve. It comes from the jugular vein in a cow, and physiologically, you know, the cow's head is down all the time, so blood would accumulate there unless it had a functioning valve sending blood back to the heart. So the valve works quite well. And down below, you can see an ultrasound picture in the cath lab from an ultrasound probe put in through the venous system. You can actually see the valve leaflets very nicely working here. You can see the stent here, and you can see color flow showing excellent flow through that valve. So this is how we put that MELODY valve in here. It comes supplied to us, sewn onto a stent. And you can see this valve. This is actually a cartoon version of it, but you can see the valve leaflets inside. We then mount that on a catheter, and we compress it on the catheter. We then cover that, so when we're delivering it, we can deliver it totally covered. And what we do is we go from the groin usually or from the neck, go through the right atrium, through the right ventricle, through the pulmonary artery, through the connection that's there, over a wire, and then deliver this system over a wire under fluoroscopic guidance in the cath lab. And then when we get it in position, we uncover it, and then we inflate it in a two-step process, and it's put inside in the position. That valve can be made several different sizes, but it is limited to a larger size as 22 to 24 millimeters, which means it can only work in a certain percentage of our patients, but not all. The advantage of that SAPIEN system that I showed you before is when that got approved more recently, we can put up to 26 and 29 millimeters, which means the majority of now RV outflow tracts, we can put a valve in the cath lab without having to send the patient to surgery. So just quickly what it looks like, this is that patient I showed you. This is the patient I put that stent in, created PI, brought him back, and recreated the outflow tract as you see here, made it wide open and put a valve in place. And this injection of contrast in the pulmonary artery shows it doesn't come back at all, so it's a functioning valve. This is the SAPIEN valve, just to show you how it works. This is a patient with a wide open outflow tract, could not get a MELODY in there, it's way too big. So we put a stent in that area, as you can see in this picture right here. And then after we put the stent in, we deliver that valve right in the cath lab. It's not always as easy as that, but we deliver it right up into there. And then on the last picture on the right, you watch as we slowly inflate this valve while the heart is beating, partially obstructing things with the balloon that's inside there. We put that valve, open it up wide, and that valve stays in good position. So the trials, just to give you a little bit of the data, the initial IDE trials in the United States were 167 patients into it, and the Edwards trial was 74 patients into it. And this is the inclusion criteria where patients were over 5 years, greater than 30 kilograms, and had to have a conduit of a certain size, which were guidelines, but we certainly did this in conduits less than that as well, and they had to be symptomatic or significant hemodynamic abnormality. And I don't want to spend a lot of time in this, but I'll show you for the MELODY trial, and this is the data that I present, part of the data I presented to the FDA. Richard Jonas happened to sit on the FDA panel where I presented this data where it was approved, so we had a very interesting, lively discussion that day to trying to get approval of this device at that point in time. But the data showed us we did 167 patients to the cath lab. We attempted 150. We were successful in terms of having the device in place for more than 24 hours and 149 out of 150. The 17 patients we couldn't put it in is very important. risk of coronary compression, which we'll talk about in a minute, in 6 patients, but 8 patients, it was just too big. We couldn't fit the valve. The valve wasn't big enough. A lot of these patients now, if they came during the trial with Sapiens, we have Sapiens, can be treated now. Coronary compression. Biggest bugaboo for us right now, procedurally, is coronary compression, because a lot of these patients have so much abnormal coronary courses. 5% of tetralogies have abnormal coronaries. Some of these patients are ROS patients who've had coronaries reimplanted during surgery for aortic disease. And if you blow up a balloon, as you see in that middle picture, and you look at the coronary underneath it, you get the impression there that it's a little bit narrow in that coronary. So we can't see, the surgeon can see the coronary sometimes in the operating room, not always in a re-op patient. But when we see this, this goes directly to surgery. We back out when we see this, because we can't do that. And we've had to back out about 5% of all implants because of coronary compression. And I'll just show you one example of this that's really important. This is a patient who had an injection in the left coronary, testing, and then we injected in the left coronary with the balloon inflated. And then we did an aortogram to show you both the left coronary up here. I want you to watch that left coronary up there. You see it right there. Then we did an aortogram with the balloon inflated. I don't know why this is here, but you can. What do you notice there? There's no left coronary. It's bad. Not a good thing to happen in a cath lab, especially. So this is when we do test for coronary compression. This is the most important thing we do during the procedure to be sure that it's safe to do this procedure. So quickly, Melanie, the incidence of the pathophysiologic state was really regurgitation about half the patients. The rest were either narrowing stenosis or a mix of the two. 85% of the patients were New York Heart 2 or greater, which means they were symptomatic when they were operated on, when they had this procedure. And we had a procedural success, as defined by the FDA, of about 99%. The results were very good. The valve functioned very well acutely. We can see here with the RV systolic pressure, the pressure difference across the stenotic area, and the height of the RV pressure relative to systemic pressure all improved dramatically. This is true for Sapien. This is true for Melody in the trials. I just have more data with the Melody data. And here's now looking at the follow-up in both lists, in both groups. This is the mean gradient by echo in follow-up out to 6 years. We now have data out to 7 years. And this is the data from Sapien valve out to only 1 year, because we don't have as much follow-up data for Sapien, showing that there's no inherent tendency for this valve to become stenotic over at least 6 years. And the data out of Europe would say 8 to 9 years, because they had it approved earlier. So this valve actually functioned very well, at least as well as surgically bioprosthetic valves put in place, maybe even a little bit better. And if you look at the degree of pulmonary insufficiency here, you can see on the Melody valve, the red and the orange represent moderate to severe PI, and the blue color there, which is none, in follow-up is remained with no significant PI in these patients. And this is true both on the right side in the Sapien and in the Melody, that we have not seen any development of any significant PI in these patients long-term, or no inherent tendency to become obstructive. So these results look quite good. And these patients seem to have, New York Heart Association went from about 85% 2 or greater to about 80% 1. We don't see necessarily improvement in all these patients objectively by stress testing or exercise testing, but we do see improvement in clinical symptoms in the vast majority of patients. So let me just show you how we apply this to patients through a single center experience. And this data was just put together in the last couple of weeks, presented last week at the Society of Cardiac Angiography and Intervention. And I've just moved the slides over. That's why the background has changed on me. I apologize for that. But from 5/2011 to February 2016, a little less than 5 years, 114 consecutive patients were referred to us at Yale for pulmonary valve replacement. That's a good number for a program our size. We have a lot of adult patients with congenital heart disease. And some of you know Bill Glenn from the Glenn Shunt was the first person to do open heart surgery in congenital heart disease in New England. And we have a large number of adult patients, but we had a lot of patients coming to do this. The median age is 19, ranging from almost 5 years to 65 years, and ranging from 17 kilos to 161 kilos. This system, delivery system, is either 22 French or 24 French. For those of you who don't know, divide that by 3, and that gives you millimeters. And yet we have to put that in percutaneously through a vein, 7 to 8 millimeters in some of these patients. We've done it down as low now as 14 kilograms in the country. The smallest one I've done is in 16.8 kilograms. 87 out of these 114 patients are tetralogic. So most of the patients are the patients we're talking about. Interesting, 16 of them are pure pulmonary stenosis of pulmonary arterial intact septum. And we used to tell our patients with pure pulmonary stenosis the same thing we sort of told them with tetralogy. And I tell them that after I do a balloon valvuloplasty on PS, that they're not going to need anything else done. But it's kind of interesting. Patients are coming back with these diseases that we thought were much less significant than tetralogy that with quite enough symptoms due to free pulmonary insufficiency. A little bit complicated, but I'll just walk you through it quickly. Of the 114 patients, we evaluated all of them by MRI. 25 went directly to surgery. We felt they were too big for us to put a percutaneous valve in there. And most of these occurred before I had use of SAPIEN. We started using SAPIEN about halfway through this time frame. But the other 89 were referred for possible transcatheter pulmonary valve replacements. Of the 89, we tested them in the cath lab, and 15 we rejected and sent them to surgery. So between the 25 and 15, we sent 40 patients to surgery. 38 have had surgical valves, but 2 are still awaiting surgery. Every one of these patients, except 3, are patients with wide open pulmonary insufficiency. So those are the group of patients that we still can't treat very well all the time because they're just too big for currently available valves. Of the 15 that we could not do in the cath lab, 10 of them because they were too big, 3 because we identified coronary compression. 1 patient we identified, we had compressed the aorta so badly with this device that we had closed one leaflet of the aortic valve and it became insufficient. And we had a conduit tear in 1 patient, which we treated, which before we had covered stents, it was contained, and we just abandoned the procedure at that point in time. So of the 89 patients, half of them were for pulmonary insufficiency, and only a small percentage are for stenosis. The rest were of the mixed lesion. When did we choose to send patients to surgery? Well, we waited too long on a lot of these patients because if I had them back now, I would do them earlier. On PI, it was some combination of symptoms, an RV volume measured by MRI that was too high, or right ventricular ejection fraction that was reduced. Pulmonary stenosis were symptoms, and they had evidence of stenosis. I think waiting for symptoms is wrong. I think waiting for symptoms is just waiting too long, but we need to consider that we need to intervene earlier. So I'm just going to skip this particular patient right now. This is just an example of how we evaluate the patients in the cath lab to do this procedure. We do rotational angiography, and we do 3D RA reconstruction so we can see what it looks like, and we can do this online. We can put that image right on the fluoro screen as we do it. We then take a balloon, inflate the balloon, as you can see here on the right side, do an aortogram, and it shows us the relationship of where we're going to put this valve stent to the coronaries that you see right there and to the aorta. This allows us to look at whether there's coronary compression, risk of coronary compression, and or any risk of aortic compression as well. So, and when we do that, we actually we measure the balloon size, we put a stent in there to, as you can see in the middle, which is a way we have of providing a landing zone for the valve, and this particular patient had a 29 millimeter SAPIEN valve put on the right side. This is an adult who is quite symptomatic. And I showed you this before, but I also want to show you this picture on the right side of the SAPIEN valve. You can see right here with an intracardiac echo, it looks really good. It functions quite well. There's no stenosis and there's no regurgitation. So we've now followed up this group of patients, both the surgical group and the cath lab group, and within our own institution. The median follow-up is short. The median follow-up is 16 months in both, ranging from 1 to 60 in the catheter base and 1 to 40 in the surgical base. The mean gradient across that valve, no different between the two. There's no inherent instruction in the two. Interesting is that greater than mild PI, we've seen none in the catheter inserted valve so far, and we've seen 6 out of the 38 get early significant pulmonary insufficiency in those patients. And if you look at a Kaplan-Meier curve, I apologize, it's a little light, but the top line, the green line, is the freedom from greater than mild pulmonary insufficiency. And this is all done blinded by echo people, not knowing exactly what was done on these patients. We've had none in the cath lab group, and we've had a significant number now in the surgically placed group. In fact, one of the surgical phase group developed so much PI, he went back and had a catheter placed valve inside the bioprosthetic valve to have it done. So the follow-up of our group of patients, we've had one patient with a small Melody valve and a small conduit develop severe obstruction, and a second Melody valve was placed because this patient was not a candidate for surgery, turned down for surgery for a lot of different reasons. And in the surgery group, we've had one death. The patient was waited way too long. She showed up very late, very sick, and she died from unremitting heart failure. So our conclusion was that transcatheter was successfully implanted in all 74 patients in which it was attempted. So once we decided to do it, we got a valve in every patient. Of the patients who were referred for surgery, all of them were free PI and would be amenable to a transcatheter technique if we could find a valve big enough to do this, instead of having to go putting them into surgery over and over again if the valve dysfunction. And if they did go to surgery, we asked the surgeons, and I'll talk about it briefly, to set it up so in the future we can do a transcatheter valve in those patients in the future. We feel the majority of adults who require a pulmonary valve should be able to undergo an endovascular procedure with currently available valves, although not all of them, although it's an off-label procedure. So let me just finish today with just showing you what the possibilities are in the future and then talk about the complications we've now seen. This is not free of complications. We all know some of the complications for surgery, but let me show you what the issues are. First case, we have, I told you before, the very, very large outflow tracts. Somebody did a plastic model from imaging of all the different outflow tracts in Tetralogy of Fallot. So we got to sort of design a valve that can fit in a lot of different environments. And if you look at this picture, this is actually 3D RVOT dynamics from 4D CT that you can see how the RV outflow tract behaves. There's rotational issues, there's compressive issues, there's length issues, all kinds of problems. So this is the hardest group you have to deal with, the ones with a really enormous RV outflow tract. And what's been looked at, right, and actually this is how we analyze them. We're using 4D CT to see what kind of structure we put in there. Anything we put in there, if it's dynamic, it's going to compress whatever we put in there. It's under constant compression to do that. So in the patient so far, we can eliminate that compression by pre-stenting, putting in stents in there to keep it from compressing and then put the valve inside of that. On the larger outflow tracts, we really can't do that. So a new valve has been designed like this, which is a self-expanding valve, not balloon expandable, and it allows itself to conform to various different anatomies inside the heart. And that's sort of what it would look like on a model. But what's been done now is this is called the Harmony valve. It's a new valve that's about to undergo trials in the U.S. Sites are going to be chosen this June. To those with the largest that we can't treat yet in the cath lab, we're trying to figure out if there's a way for us to treat them without necessarily having to go to the operating room. We've done this valve now 20 times in a research clinical. 18 of the 20 have been incredibly successful, doing well. Short term, 6 months to a year. 2 didn't work, and they were sent to surgery successfully and had a surgical implanted valve. So the FDA has sort of said to us, we're going to let you go ahead with another 50 patients on a limited ID trial, and we're going to see what happens with that valve. Well, that can handle outflow tracts. I told you we can go up to 29 millimeters. This can handle outflow tracts up to 40 to 45 millimeters in diameter, which we can't touch right now. So let's finish with the complications in transcatheter pulmonary valve replacement and what we've done about the complications. Stent fracture. When I presented our data to the panel, the FDA, myself and 2 other people, to get approval, we had a 14% incidence of stent fracture. That's unacceptable. This is stents we put in there in the RV outflow tract that over a period of time would come back with stenosis, and they come back with stenosis not because the valve leaflets failed, but because the stent collapsed. It was a compressive. It broke like a paper clip, so to speak. It just fractured. We learned that we can't. We were putting this in a hospital environment in the RV outflow tract. And what we did, we learned if we could put stents in there ahead of time, build up the area, make them wide open, and then eliminate the compressive forces, still realizing you're putting this between the heart and the sternum, we could decrease the incidence. This has increased. That should be 1%, not 15. I apologize. That 5 should be 1%. I think I hit the cap button. But that's 1%. We've gone from, a terrible mistake, that went from 14% to 1%. So that's when I do this at 1 o'clock in the morning. But this is significantly, we eliminated it as a problem. It's no longer a real problem in any one of the valves we put in there. And SAPIEN especially, the SAPIEN stent is 3 times stronger than the Melody stent. So it's really not been a problem at all. Conduit tears. If we have a tight conduit or a tight obstruction and we put a balloon in there with a stent and open it up, we have seen a small percentage of tearing with either contained bleeding around the conduit or on rare occasions, uncontained bleeding into the chest, for which we are very thankful that our surgeons are around when we do this. However, we've also found a way to treat that in the cath lab without the need of going to surgery. And we're also working on a way to prevent it from happening in the beginning, is that with the approval of covered stents, which has just been approved this past January and February in the United States, if you put a stent in there that's got covering on it completely, I'm not saying we're reducing the incidence of tears, but we can't see them anymore. They're covered, and so they're sealed as soon as you put the stent in. And we've sort of feel just about every one of these patients can be prevented or treated in the cath lab with a conduit tear. Coronary compression is a big bugaboo. You've got to be sure you're not going to compress a coronary. It's not unique to the cath lab to do that. We've all seen patients come to the cath lab after surgery and we can see coronary gone from one side to the other because it's been compressed by a conduit on multiple surgical procedures. Pretty rare, but it does happen, but we have to avoid that. We have no bailout if we do that in the cath lab, except on ECMO or something like that when it happens in the cath lab. So I've never seen it. The United States has been one documented case that I'm aware of. There's probably more that have not been documented. They did the testing but didn't believe some of the pictures they actually got, and you got to be very careful. If there's any question, we're out of there. We're going to send them to surgery. Endocarditis, I'm going to finish with that. There's been a lot of literature published out there about the high risk of endocarditis in the Melody valve to start with. And some people in Europe, one program decided we're not putting any more Melody valves in because there's too much endocarditis, we're going to go to SAPIEN valves. I'm going to show you in a minute. There's absolutely no difference between Melody and SAPIEN in the incidence of endocarditis to do that. So what's the background? These bioprosthetic valves are all at risk for bacterial endocarditis. We know left-sided bioprosthetic valves, aortic and mitral, the incidence of endocarditis is up to 3% in 1 year and 3 to 6% in 5 years. This is not prospective randomized trials. These are retrospective studies looking at on this data. And also there's no data out there, and we talked about it last night at dinner, for bioprosthetic valves in the pulmonary position. There's just no data out there. No prospective data for us to compare this to. And this is a bad disease. And now these are all the recently transcatheter valves, SAPIEN, Core valve, and Melody. Endocarditis has been reported on all 3 of these valves. So there is a real risk. So what is the risk? It's hard data to come by. This data you see here in the Melody trial and the SAPIEN trial is prospective data. So these patients have been followed as well as anybody else, better than anyone else prospectively. This whole group, we're mandated by the FDA to follow these patients for 10 years, the whole group of patients. So if you look at the freedom from endocarditis at 5 years from Melody implant and SAPIEN implant, the left and right columns here, these are all endocarditis. It's not necessarily valve endocarditis. This is all endocarditis in patients. It's around 88 to 90% is the freedom at 5 years. I do not know what it is for bioprosthetic valves in the pulmonary position. We don't have that data, and we need to get that data one way or another going forward. It's definitely, at least probably, some literature would say it's 3 to 5%. And in a sense, that's not the same thing as freedom from, by the way. It's really comparing apples to oranges here. We have an incidence of 5 to 6% out 5 years, and bioprosthetic valves about the same. But this is, I think, what's important for me is that's the way of looking at it is freedom from. So let me just finish by saying the consequences for residual hemodynamic abnormalities following repair are very serious. Transcatheter therapies are currently available and being developed as an adjunct to surgical management, and they're approved and they're being expanded in their use. But maybe we need a new algorithm completely, and I love Richard to talk about it. For the initial surgical procedure to repair tetralogy of Fallot, we need to maximize attempts to preserve the RV outflow tract with minimal insufficiency and allow maybe for some degree of stenosis, which we didn't want to in the past, but I think some of the changes in surgery allude to that. For the post-op patients with hemodynamic abnormalities, we should consider placing a competent pulmonary valve much earlier than we do right now. And if we're going to do that, we should do that in such a manner that would limit the number of future open heart surgical procedures. So if we're going to be able to do it in the cath lab, maybe we can put a percutaneous valve in, and we can put another percutaneous valve inside those valves. We've done that before in certain situations. If we're going to go to surgery for this, we've asked them to put in a landing zone that's adequate for future transcatheter valve implantations when they put in bioprosthetic valves. Too often in my own institution, the surgeon goes in and a 9-year-old, and a 10-year-old, or a 12-year-old and puts in a 19 or a 21 bioprosthetic valve. That's pretty useless for me. That's guaranteeing that patient's going to have to go back to the operating room, because that's not big enough for me to put a percutaneous valve in there. I need a bigger bioprosthetic valve. We have this active discussion all the time to do this. I'm just going to leave that with you at this point in time. It's a lot of food for thought. We have a new technique that we need to scrutinize, just like we've scrutinized the old surgical procedure, the Tetralogy of Fallot. Thank you very, very much.
Thanks, Bill, for that great presentation. As a reminder, there'll be a reception in the mini atrium afterwards if you'd like to speak with Dr. Hellenbrand a little further. And we'll go ahead and open it up to questions.
Oh, yes. Thanks, Bill. Thanks, Bill. We really appreciate you coming. For the residents in the back, Bill was a role model to me when I was a resident too many years ago to count, but thanks, and we really appreciate you coming as the annual Garbose lecturer. Despite that, I'm going to ask you a hard question.
You
taught me well.
I won't expect anything less. Go ahead.
So, with all of the advances in transcatheter therapy and surgically placed pulmonary valves, there has not been a reduction in the incidence of either ventricular arrhythmias or sudden death despite these advances. So why do you think we're not able to prevent that?
I think it's pretty much what I've said before. I think we wait way too long to do this. I think if I had a patient now who is totally asymptomatic at 10 years of age or 8 years of age, and he's got some reduced function or he's got very enormous volume, if I know I could put a valve in him that would last forever and never needs to be replaced, we probably operate on that patient and put a valve in there. We don't have that success, but I do think we have the ability to correct the physiologic abnormality of PI. Not to correct the incision in the right ventricle, it's always going to be there unless newer techniques are different. I think the best answer I can give you is we don't do it soon enough. And I think we just need to follow these patients longer term. I think we have the data, the control population. I think we need to figure out if we can intervene much earlier, especially if you don't have to go to the operating room repetitively. I think we just need to intervene much, much earlier. But I think your point is extremely important, that what we've created, we thought we did a good job, it comes back 30, 40 years later. And I think that's an important thing for all of us to remember when we take care of these patients. Bishop.
Bill, beautiful presentation. Thank you. Thank you for coming to home territory. It's wonderful for us not to be meeting either on an FDA panel, or the other site we usually meet is a debate with about 2,000 cardiologists, and I'm the sole surgeon arguing in favor of some surgical approach to a problem. So thank you for coming to home territory. You mentioned the evolution of surgical techniques. I think the most important one has been to avoid shunts. In the early years of tetralogy surgery, the initial procedure was a shunt, which resulted in distortion of the pulmonary arteries and in increase in pulmonary resistance. And I think avoiding shunts and doing early primary repair has been a very important advance in the surgery. But the other important evolution has been to recognize exactly what you've been emphasizing today, which is that pulmonary regurgitation that we create with a transannular patch has long-term consequences, and that really what surgery should try to achieve is a balance between leaving a little bit of residual stenosis, even leaving a valve that's a bit too small, but has an acceptable transvalvular gradient, so that you've got a balance of stenosis and regurgitation. So we work a lot harder to preserve valves these days than we used to. I'm in the problem of endocarditis in these catheter implanted valves is a really interesting one. I wrote an editorial about it recently that you probably came across. And I have to say, you know, what's been really disturbing is some of the kids have shown up really sick. I mean, we treat endocarditis, and it's usually subacute bacterial endocarditis, a grumbling fever, and then a positive blood culture turns up. Some of these older teenagers, young adults have shown up with renal failure and practically dying from profound low cardiac output. So that's been one disturbing aspect of it. It's also hard to recall surgical cases that have shown up, and it does seem that there's something different about the bovine tissue, perhaps, which leads to my question. I mean, your group was fortunate to have Toshi Shinoka at Yale. He was previously with us in Boston working on the development of tissue-engineered valves. So what do you see as the future of some form of tissue-engineered valve when hopefully these problems of immune susceptibility may be overcome?
You know, couple of comments. I'll do the last part first. John Meyer, as well as Toshi, have been working for a long time on tissue-engineered valves from the patient's own tissue to develop these valves. It's been a long struggle. I think we would really like to see tissue-engineered valves become a reality. We all would prefer to get rid of some of the immunologic consequences that we're talking about, be it infection, be it degeneration of the leaflets, whichever it might be. I think we're a long way away from getting that to make that work. We've all said, we've talked to the people at our place, and I talked to John about it as well, is that the goal would be is to have a tissue-engineered valve we can deliver through a catheter in this kind of situation to make it work. That's the goal. It's not going to happen while I'm still practicing. And it's just a lot of problems along the way to make this work. The only thing we've done so far with tissue-engineered systems in congenital heart disease, we've done a few conduits, Fontaine conduits with tissue-engineered veins. You know, that Toshi, his group had allowed us to do, and there are some problems with that as well. So we got a lot of issues going forward. But theoretically, I think it's the right thing to do. You made a comment about the timing of surgery. I find it interesting you saying that because I agree shunts are bad for you, but I'm not sure operating on a neonate repair of tetralogy of Fallot is good for the degree of pulmonary insufficiency we see on those patients, because those are the patients you frequently have to go transannular, because they're pretty small if you have to operate them in the newborn period rather than doing a shunt. And there it comes in the line is whether you want to use an alternative approach not to damage the pulmonary arteries, like an RVOT flow tract stent, which we've done now in a number of small preemie tetralogies, including coronary stents in that area. I'm just a little afraid operating on neonates as primary repair is also associated with a higher incidence of free PI, as best as I can tell in the surgical group. So, still an interesting problem. The endocarditis issue, real bugaboo, and I don't know what to tell you, but I think it's a little unfair right now to saying they present sicker, because if you look at bioprosthetics in the adults, 20% of them present in profound septic shock with bioprosthetic valve. We don't see it as much on the right side so far in the pediatric age group, but in the adult age group, they present very sick with profound septic shock. So I don't think it's all that surprising. Yes, any other questions?
I'm Pranav Sinha, one of the surgeons. That was an excellent presentation. There is plenty of interesting surgical data on PVRs where we see that bigger is essentially not better, and bigger valves are more likely to have structural valve degeneration. Do you have similar concerns as we step into the world of sapiens and implant much bigger percutaneous valves?
It's a good question, because there's some data that if you go too big in surgical literature, they have an earlier problem with function. And I don't know if it has something to do with how it lies after you close the chest versus how it lies when you put it in. But the way we don't have the issue of having to worry about the chest being closed in these leaflets. And the data would suggest on the short term that it's not a problem so far. And that's very clearly true in the aortic position. These valves work very, very well long term without insufficiency, talking about the sapien valve. We'll see on the right side or not to make that work. But I think it's a little different than an environment of sewing them in and then having to close the chest and close everything versus us putting it in a totally circularized area we've created with a stent, and there's no compression on those leaflets.
Well, I was talking to the long-term freedom from structural valve degeneration. And the majority of valves that were used in that series were the Edwards Perimount, which essentially is the same bovine pericardial leaflets.
Don't know the answer. You know, I can't answer the question. They're Perimount valves, but you know, the question is how they were put in place to do that. But I have to tell you, if we looked at our data, our surgical data, we don't use the Perimount valve very much. It's using two different valves. Mosaic valves been used, and a lot of the CE valves being used. And we see pretty significant degeneration over 3 to 5 years, and a good 20–30% of those bioprosthetic valves put in place. I think we need to do a control trial forward and back, and maybe it's time to look at it consecutively rather than retrospectively.
Thank you.
Thanks very much.
Thank you very much, everybody.